Welcome to the video for the participatory guide for planning for mass administration of medicine. This video is to be used alongside the PGP. It comprises of 4 modules that can be played and paused throughout the training to show real-life examples of taking a participatory approach to planning and implementing with a focus on equity so that no one is left behind. The primary goal of the participatory planning guide is to help implementers plan relevant activities for MAM in order to improve coverage rates, ensure equity in treatment coverage so that the poorest and the most marginalized are reached during MAM interventions, improve timely planning of the MAM activities, and improve equity and equality of health coverage. Module 1 defines the outline of the PGP and how it can be used. It also provides an overview of the roles and responsibilities for the different stakeholders, including NTD implementers, communities, community leaders, and stakeholders from other sectors. Each module reviews what works well and what doesn't work well based on evidence. Therefore, within each section, you will see reflections from NTD implementers in rural and urban contexts. Take note of how these different contexts required different approaches. The PGP is designed to present a shopping list of actions within mass administration of medicines. You may choose which one would work best in your context, considering population need, diversity, and budgets available. You can now pause this video and take time to read and discuss Module 1. Read about the different roles and responsibilities of people involved in participatory mass administration of medicines. Look at Figure 1. That shows the whole MAM process. Think about what this means to you in your context. Module 2 shows community engagement strategies to make sure no one is left behind when planning and administering medicine. It details how to hold a participatory planning meeting, stakeholders to invite, and how to draft an agenda for meetings. Community engagement has always been the center of NTD program delivery, specifically for MAM. Engaging communities effectively is likely to increase program acceptance and support programs in meeting coverage targets. There are different techniques of engaging the community in the light of wide inclusion, considering age, gender, religion, marginalized population, like people with disabilities and migrants. Strategies like transit work and social mapping can be used to identify both current and potential structures that can be relevant for different processes of MAM, like communications, sensitizations, mobilization, and administration of medicines. Those to be engaged in transit work and social mapping should be those who are familiar with the community and should be drawn from different subpopulations that can provide different views. Example, community leaders, women leaders, religious leaders, youth leaders, including young females. Some key questions in considering the structure should be: what process of MAM can take place in the identified structure? What group of people can or do use these places? What is or could be the challenges of using the place? Who will be able to come to these locations? Community engagement in this context is the meaningful, respectful, and fit-for-purpose involvement of community members in one or more aspects of planning for NTD programs, and may include involvements during the planning process, to defining its delivery structure, to stages of implementation, data collection, and suggesting improvements. The PGP provides tools and step-by-step instructions so you can also conduct these exercises to better understand the community you are serving. Many people are still left out in MAM activities. You need to reach everyone to make it fair and equitable. In the past, people with disabilities, migrant groups, and some women have been missed out of MAM for different reasons. What can you do to make sure this doesn't happen again? See the PGP for examples. Learning packs will also be of great help. CDDs are community drug distributors. Choosing them can never be a random act. It needs careful planning, as they need to know or be part of the community where they will be interacting with. There should be clear emphasis on the criteria for selecting community drug distributors, such as volunteerism, gender balance, and selection from the community.
Orúkọ mi ni Ọmọbọ́láńlé, ọmọ Owójé ni mí, mo ń ṣiṣẹ́ ní abẹ́ CDD.
Èmi ti ń bá wọn ṣe tipẹ́. Bóyá ti tó bí round kẹta tí mo ń ṣe báyìí. Àárín ìlú ta dẹ̀ ń gbé náà ni gbogbo àwọn èèyàn ti mọ ojú wa tá bá mú nǹkan débẹ̀. Even gbàgbà tá pín ògùn yẹn ní ti upper last year. Àwọn ibì kan tó ti reviews tí wọ́n gbà tá débẹ̀ láàárọ̀ yìí. But inflex pé a ti bá àwọn ọmọ wọn kan níbẹ̀ láàárọ̀ tó jẹ́ pé àjọ wa láàrin ìgboro tá fi wá wọnú abúlé yẹn lọ. Ó ṣe wá bá wa ṣàlàyé fún wọn pé àwọn èèyàn àwọn ni o. Gbogbo èèyàn ará abúlé ó yẹ máa bọ̀. Gbogbo wọn wá fún wọn lóògùn yẹn.
It is important that community leaders are involved in the selection of CDDs, and even more so that they are trained appropriately to be able to answer any questions asked by the public and administer the medicines correctly. This micro-planning meeting is a local level meeting that aims to have a bottom-up participatory approach to planning so that the local context may be fully considered. It is focused on detailed implementation covering budgets, planning, advocacy, sensitization, mobilization, medicine logistics, MAM implementation, and review. Relevant stakeholders need to be invited by letter at least 2 weeks in advance of the meeting. Remember to send a reminder 2 or 3 days before the meeting to confirm attendance. Present at this meeting should be LGA team members, a representative of the state NTD team, and others such as the Apex nurse, the frontline health facility staff, or ward focal persons. Also present should be representatives of the community development communities, community development associations, religious groups, and so on. When picking a location for your meeting, try to think about a meeting hall that is accessible and comfortable for the number of participants you want to accommodate, as well as being away from the general office distractions. The local government area micro-planning meeting should take place one day over 5 to 6 hours. If this is too long for your stakeholders, you could consider spreading the meeting over 2 days.
NTDs are neglected tropical diseases. In those diseases, we have lymphatic filariasis, onchocerciasis, schistosomiasis, soil-transmitted ailments, trachoma. For physical impairments, you can see people who have lymphatic filariasis, who have elephantiasis. So at the end of the day, they are physically challenged. It will amuse you to know that a lot of people do not even know that elephantiasis is caused by a mosquito.
Identifying a clear agenda and sticking to it will be essential to ensure people remain engaged and know what to expect to do. The agenda is an example of things to include in this meeting, but can be adapted for your specific LGA needs. At this meeting, the LGA teams in Kaduna are developing action plans for advocacy, sensitization, and distribution. Participants are issued with a work plan template to fill in as they discuss each stage of the MAM process. A key aspect of this level of planning is budget, which must be done for all areas captured in the plan. The budget must be both in areas of resource allocation and personnel.
The program is well inclusive because anytime when the training is about to start, they will seek for our attention to send a representative. They will ask us to mobilize our people so that they will benefit from the drugs.
We will be able to attend this program, and we have acquired a lot of knowledge that has to do with mosquito regarding elephantitis. We must make sure we use some of our meetings avenue to step down the knowledge we acquire from this particular 2 days sensitization workshop.
The second level of planning for MAM that should be organized is called state macro planning. Here, the plans developed by different LGAs during the micro level planning are synced and fed into a single state macro level plan. The ideal flow of planning should be from local government upwards to the state level, so as to ensure that each LGA is catered for by a statewide plan based on circumstances and peculiarities. It is important also to mention how dates must be tied to specific activities and persons to carry out those activities clearly identified and notified. Macro planning at state level is very similar to that of the micro planning at LGA level. Present at these 2-day stakeholders meeting should be Director of Public Health, State NTD Coordinator, Zonal NTD Coordinator, State NTD Team, representative of the Federal Ministry of Health, LNTDs, representatives of the Community Development Committees, CDC, committee and implementing partners like site savers, and representatives from various interest groups. A key aspect of this level of planning is budgets, which must be done for all areas captured in the plan. Budget is very important and it must be contextual. Whatever works in the rural area might not work in the urban area. In the rural area, the budget should cover enough CDDs and logistics for these drugs. The same thing with urban setting, so that the MAM process will be a success. This budget must also cover supervision which is a key aspect of MAM. If this is not covered, MAM is bound to fail. Remember that the mode of communication with which information is conveyed to the participant is very important. A printed copy of the plan needs to be pasted at strategic locations within the LDA Secretariat and other related places for persons to follow the plan and ensure its implementation. It is important to point out the need for the final draft of the plan to be shared with every member of the planning team through email, WhatsApp, or printed copies. After a successful plan, endeavor to put in place a reminder mechanism so that everyone will remember to discharge their roles as agreed. And if there are reasons that aspects of the earlier plan must be changed, the amended copies must be shared to update persons responsible with the new timelines and changes. You can now pause this video and take time to read and discuss Module 2. Read about how to plan meetings, look at the draft agendas, look at the stakeholders mapping exercise found in appendix, and read what works well and what doesn't in participatory planning. Module 3 will guide implementers on how to develop an action plan in terms of stakeholders to be involved, resources needed, assessment of potential challenges and ways to mitigate them, and identify tools and methods of communication in different contexts. One of the major activities during micro planning and macro planning is developing an action plan. The action plan is a comprehensive plan that carries proposed activity, start dates, end dates, persons responsible, strategy for carrying out the activity, resources needed, and budget. The action plan also covers every step in MAM implementation, such as advocacy, sensitization, census updates, training cascade, medicine administration, reverse logistics, and review meetings. Training is important for all categories of implementers of MAM. It is the only means through which basic knowledge around implementing the program is passed to those to discharge that role. Emphasis should be made that persons attending this training must be persons who will return and implement the program and must not relinquish the task to someone who was not part of the training. Training should take place in conducive venues with space enough to have participatory exercise like role plays and other interactive sections. As for the ideal length of training, 2 days are recommended and 5 hours for each day. Of course, that depends on what works for each situation.
Zai ci gaba da Hausa. In aka shiga gida za a yi sallama, a yi gaisuwa, a faɗi makasudin dalilin zuwan mu wannan gida. Ba ana so in an bada magani da zama mutum na da rajista, an ɗauka bayanan shi da komai da suna da shekarar shi da namiji ne ko na mace ne. Duk wani abubuwan yana daga cikin abubuwan da za a shigar da shi a cikin rajista.
An alternative training process supposes that a number of cadre of implementers at the LGA level are trained together in order to have uniform information that are key for effective implementation of MAM. Doing so will limit the margin of errors in carrying out roles compared to having separate trainings like in the traditional method. Training should always be interactive and should include, where possible, role plays.
Wannan maganin an ce yara da suke kasa da shekara 5 ba za su iya a ba su wannan maganin ba. To sai ga wani tambaya yanzu shine idan aka ja an samu mace da tana da juna biyu yanzu nan za a bata wannan magani kuma tana da yaro a ciki.
Banda masu ciki, banda masu ciwo kaka bashi, sai masu shayarwa, masu breastfeeding, amma in bata kai 7 days ba, when she's after 7 days, ka gane?
To deliver this training, therefore, requires collective involvement of Medical Officer of Health, NTD coordinator, the health educator, SMOs, the SNTD staff, the LNTD team, and the FLHF. Meanwhile, things to include in the training for easy comprehension may include medicines, the dosage, the dose pool, therapeutic and geographic coverage. Materials required to carry out the training may include IEC materials, audiovisuals like projectors, and writing materials for participants. Following training and feedback sections, CDDs should conduct 2 weeks sensitization in the community where they are to implement the program before commencement. It is important that the CDD are supplied with adequate IEC materials, medicines, dose pools, and treatment registers. Advocacy is informing the public, especially key stakeholders, about MAM. Sensitization is talking to the community about MAM. In both cases, once there is awareness and a sense of ownership, these stakeholders can better inform their members and the community at large. People that fall in this category include various women groups, market leaders, community-based organizations, artisan associations, and so on.
Sarkin hayin banki da kewaye dan Usmanu jikan isu uban isu rana ko ba ki lafiya ka fito.
Kamar yadda sarki ya ba mu izini mun zo shigo ne domin mu wayar mu al'umman garin hayin banki kai akan wa'annan cututtukan da ake nuna wa halin ko in kula wato cututtukan muna ce musu neglected tropical diseases, cututtuka ne guda 5 da muke da su a Kaduna State. Za mu fara gudanar da wa'annan ayyukan ne insha Allah daga ranar Talata za a fara ganin magani na shigowa gida-gida. So mun shigo ne domin mu sanar mu al'umman wannan garin idan yaran nan sun shigo a ba da haɗin kai a karɓi maganin nan 100%.
Ji daɗi da irin wannan kokari da kuke yi kuma mun ga abin da kuka yi a baya. Allah ya kawo mu wannan lokaci kun zo kun sanar da mu za ku zo muna masu maku tabbacin cewa al'umma banki mutane ne masu zaman lafiya masu ansa.
Advocacy is a sort of gaining ground, going for traditional blessing of any program. The importance of this advocacy is for your program to have a soft landing and for the acceptance of the program by the community. Because if you enter a community through the traditional leaders or through the religious leaders, the community will accept your program because they have much more belief in their religious leaders or the traditional leaders.
The town announcers must have appropriate information, such as the name of the medicine, what it is used for, the importance of using the medicine, the date of commencement of MAM, where and how distribution of the medicines will be done. Also, the message should include those eligible to take the medicines in terms of age brackets, that is 5 years and above, and that women who recently gave birth must not take the medicine till 7 days after delivery. This approach works well in rural settings and may be less effective in urban settings. Nigeria has a wide radio and television followership, thereby making it one of the most veritable means of reaching a wide spectrum of the population at the same time with the same message at a reasonable cost. This will take the message even to the hard-to-reach communities.
The Ogun State Ministry of Health, in conjunction with UNICEF, is conducting a mass treatment of neglected tropical diseases, NTDs, which are a group of communicable diseases associated with poverty, poor housing conditions, and inadequate water supply. They include onchocerciasis or river blindness, inoru, and elephantiasis. This group of diseases cause...
Other means of sensitization via mass media are posters and handbills, town announcers, and public announcements. There are different ways to distribute the medicines within the communities. Some methods are more appropriate in rural or urban settings, and therefore careful considerations of the method of distribution should be considered in the planning stage. Methods of distribution of man can include house-to-house medicine distribution, fixed post distribution in places like churches, mosques, health centers, etc., and the sweep method, which involves medicine distribution to people wherever you meet them.
My name is Margaret Bulus. I'm a community volunteer. I was trained as CDD. When I go into the community, the first household I go in, I greet them. I will introduce myself and tell them the purpose of my visit. I will ask for the head of their household. First, you ask for his name. Second, sex. Third, age. I use my measurement stick. That is a stick that we're being given to us. So that one is the one that indicates, show us how to minister to the drugs to the people in the community. Because we have from 1, 2, 3, 4. So it's according to your height. If your height is up to 4, we give you 4. If your height is up to 3, we give you 3. If it is 2, we give you 2. If it is 1, we give you 1.
It is important to emphasize the need to respect cultural and religious peculiarities and to refrain from going to restricted places. For example, a male CDD is not allowed entry into certain Muslim homes. CDDs should go in twos so that we can have one recording and one administering the medicines. The full process of determining the eligible through asking of age of children at the point of distribution and measuring of the adults to determine the appropriate dosage should be shown. To be included also is the process of filling the register by the CDDs. It should be mentioned at this point that medicines handed to persons should be swallowed at a point as part of the direct observed therapy which the NTD program encourages. There are alternative approaches to MAM distribution. Fixed post is the use of health facilities or other known structures as distribution points. The use of the health fixed point for medicine distribution provides opportunity for many community members who may not be at home during house-to-house distribution to be able to access the medicine. Temporary mobile posts is using a well-known area or structure in the community selected as temporary distribution point. Example, house of community leaders, a church or mosque. A new strategy was started in Ogun State, known as Health Workers Administration of Ivermectin, where health workers administer the medicine in a fixed point, while CDDs served as mobilizers.
People in the communities are selected as CDDs. But come 2018, when we had the second implementation in Ijebu-Ode local government, we met with the medical officer on health, that is Dr. Akin Baju, and it was like they would prefer we use health workers. He actually mentioned some reasons for coming up with that kind of strategy. The very first one has to do with acceptability. In Ijebu-Ode, there are elite people, there are people that are well educated. So in a particular team, we have the health worker, we have a recorder, and we also have a mobilizer.
The name of this method we are using in Ijebu-Ode is Health Worker Ivermectin Administration. Among the other local governments, we scored the highest because of the method we use.
Supervision is an important aspect of MAM implementation to ensure implementers feel appropriately guided, supported, and improved in their performance. Some of the activities to be supervised are training of the NTD team, FLHF, and CDDs, in addition to transportation, allocation of medicine to the local government and the health facilities, distribution of medicine in the community, and reverse logistics. Supervision should commence 1 week prior to training activities and continue until the end of MAM. This ensures that important preparatory activities like census update was carried out and data tools are properly filled during the mass administration of medicines. Supervision also provides an opportunity for challenges to be identified while the program is ongoing and the identified challenges corrected immediately. Mop-up is the process of revisiting the houses or the area in order to treat people that were initially absent during the first visit. Reporting is a crucial process of the NTD program because it is only through reports that the program can keep track and identify areas of strength, weakness, and make efforts to improve delivery. Official data tools should be used to capture the reporting and monitoring of MAM, from the level 0 handled by the CDD to level 1, which is filled by the frontline health facility staff, to level 3 by the LNTD. It is important to having valid data entry that is properly recorded, collected, and collated. Before requisition of medicine, a census update is supposed to be conducted by CDDs, which will determine what will be requested from the central medical stores. After the census update, the state will now request for medicines from the NTD National Office using recommended template forms. The National Office reviews the request and sends to the central medical store. The medicine allocation flows down from the Federal Central Medical Store to the State Central Store, then to the LGA, then the LGA allocates to the frontline health facility who will allocate to the CDDs, and the CDDs will finally distribute medicines to community members. It is expedient to use stock allocation issues and receive vouchers when issued medicines at all levels of collections. While giving reports, medicines that have not been administered are accounted for from the CDDs back to the state central store. You can now pause this video to take time to read and discuss Module 3, which gives detailed explanation of what is required to plan for MAM in an equitable and participatory way. This module will help you have a clear plan how you will capture learnings throughout this year's MAM implementation cycle. Draw stakeholders together to bring everyone's learning at the end of the process and use these learnings to shape future planning activities. The aim of the action log is to look at the activity, persons involved, what worked well, what did not work well, and the areas of improvement. It is important also to document photographs of activities that improve program implementation. There are 2 levels of review meetings, namely LGA review and state review meetings. There should be a plenary session to make presentation about the performance of the LGAs during the last MAM. A quality time should be allotted to discuss ways for improvement. The stakeholders to be present at the review meetings include implementers at the community level like CDDs, FLHS, FLHFS, LNTDs, CBOs, World Health Committee, Social Mobilization Committee, religious leaders, women leaders, and youth leaders. We hope you found this video useful to use alongside the PGP. The PGP was developed from implementation research conducted by the Countdown Research Consortium in partnership with NTD implementers from Ogun and Kaduna State and Federal Ministries of Health. The project brings together NTD researchers, policymakers, practitioners, research specialists to generate new knowledge and assemble necessary information about the realities of increasing the reach and impact of NTD treatment campaign in different contexts. The specific aim of the Nigerian project is to increase the effectiveness of NTD program with focus on reaching the poor and the vulnerable people and to enhance community ownership and participation of the NTD program. We thank you for taking the time to engage in this participatory way of working.